Welcome to the show, everybody. I'm Karen Whitaker, here with Heather Murphy. And Heather, we are diving deep into the lower respiratory tract today. I want to start with a case that still makes me hold my breath. Years ago in the ICU, I had a patient post-stroke struggling with dysphagia who silent aspirated during a tube feeding. Within 12 hours, they went from a mild cough to full-blown respiratory failure.
Oh, Karen, silent aspiration is absolute nightmare territory for a nurse. When we teach our South University BSN students about pneumonia, we have to start with that exact pathophysiology. It's an acute infection of the lung parenchyma, and it's still the fourth leading cause of death worldwide. The organisms get down there in three ways: aspiration of normal flora, inhalation of microbes, or hematogenous spread from an infection somewhere else in the body.
And once those bugs settle in, the inflammatory response is brutal. Neutrophils rush to the scene, inflammatory mediators are released, and the alveoli fill with fluid, red blood cells, and debris. That's consolidation. It completely blocks gas exchange. On your exams, you've got to differentiate how a patient acquired this. Community-acquired pneumonia, or CAP, happens in patients who haven't been hospitalized or in long-term care within 14 days of symptom onset. But hospital-acquired, or HAP, begins 48 hours or longer after admission.
And if they are intubated, 48 hours after that endotracheal tube goes in, any new pneumonia is classified as ventilator-associated pneumonia, or VAP. This is where nursing care literally saves lives. You must memorize the 4-step VAP prevention bundle. Number 1, elevate the head of the bed to at least 30 degrees. Number 2, perform meticulous oral care with chlorhexidine and suction. Number 3, remove any condensed moisture from the ventilator tubing. And number 4, turn the patient every 2 hours.
That oral care piece is huge. If we don't clean that mouth, those microorganisms just slip right down past the cuff of the tube. Now let's talk about those risk factors for aspiration pneumonia specifically. We're looking at anyone with a decreased level of consciousness, a depressed cough or gag reflex, difficulty swallowing, or anyone with a nasogastric tube, whether they're getting active tube feedings or not.
Right, because that NG tube keeps the lower esophageal sphincter slightly open, allowing gastric contents to track up and over into the trachea. Now, if a patient develops a massive pleural effusion from their pneumonia and needs a thoracentesis, we have some critical post-procedure assessments. A little serosanguinous drainage is fine, but you must monitor for an increased heart rate, rapid respirations, coughing up blood-tinged frothy sputum, and chest tightness. Those are red flags for pulmonary edema or a mediastinal shift.
A mediastinal shift is a true emergency. The entire heart and great vessels are physically pushed to the opposite side because of sudden pressure changes. Speaking of highly contagious, high-stakes respiratory diseases, let's move to Mycobacterium tuberculosis. This gram-positive, acid-fast bacillus is spread by tiny airborne droplets, 1 to 5 micrometers, that can hang in the air for hours. Remember, TB is not spread by touching or sharing utensils. It requires close, frequent, or prolonged exposure.
And there's a massive difference between latent TB and active TB disease. With latent TB, the bacteria live but don't grow. The patient has no symptoms, doesn't feel sick, and cannot spread it to others. But active TB, they are highly infectious, presenting with a dry cough that becomes productive, fatigue, malaise, anorexia, unexplained weight loss, low-grade fevers, and those classic drenching night sweats.
Now let's decode the TST, the tuberculin skin test, also known as the Mantoux test. This is a classic area where students trip up. We inject 0.1 milliliters of purified protein derivative intradermally into the ventral forearm. We must read the induration, the raised, hardened area, not the redness, 48 to 72 hours later.
Yes, it's the hardness, the induration, that we measure in millimeters. And the rules are very specific based on risk. An induration of 15 millimeters or more is positive for low-risk individuals. 10 millimeters or more is positive for high-risk individuals, like healthcare workers, injection drug users, or people living in overcrowded settings. But for the immunocompromised, like patients with HIV, an induration of just 5 millimeters or more is considered positive.
If they test positive, or we highly suspect active pulmonary TB, they go straight into airborne isolation. This means a single occupancy negative airflow room with 6 to 12 air exchanges per hour. Everyone entering that room must wear a fit-tested HEPA or N95 respirator mask. If the patient has to leave the room for a procedure, they wear a standard surgical mask to contain their droplets.
Once isolated, we start the 4-drug intensive treatment phase: isoniazid, rifampin, pyrazinamide, and ethambutol. You must know the side effects of these drugs. Isoniazid and rifampin both carry a high risk for hepatotoxicity, so we have to monitor liver enzymes closely. And rifampin has a very striking non-harmful side effect that patients must be warned about. It turns urine, sweat, tears, and saliva a bright orange color.
I always tell my students, warn your patients about the orange sweat before they ruin their favorite white t-shirts. If the bacteria are susceptible to all 4 drugs, we eventually stop ethambutol and move into the continuation phase with just isoniazid and rifampin.
Let's transition from chronic infections to sudden violent impacts. Chest trauma can turn a stable patient into a critical rescue situation in seconds. Think about a simple rib fracture, usually ribs 5 through 9 because they're the least protected. It sounds minor, but the pain causes splinting and shallow breathing. If the patient won't breathe deeply or cough because it hurts, they develop atelectasis and pneumonia. We have to manage their pain with NSAIDs, opioids, or nerve blocks so they can use their incentive spirometry. Never tape or bind the chest.
Oh, absolutely not. Bounding the chest just guarantees they won't expand those lungs. And if those ribs fracture in multiple places, we get flail chest. This happens when 3 or more consecutive ribs are fractured in 2 or more places. This creates a completely unstable chest wall segment that exhibits paradoxical movement. When the patient inhales, the flail segment is sucked in. When they exhale, it bulges out. It's the exact opposite of normal chest expansion, and it drastically increases the work of breathing.
It's terrifying to watch because the patient is literally fighting for every breath. And that trauma can easily lead to a pneumothorax, where air enters the pleural space, destroying the negative pressure and collapsing the lung. An open pneumothorax is a sucking chest wound from penetrating trauma. We treat this in an emergency by covering it with an occlusive dressing secured on 3 sides. When they inhale, the dressing pulls tight, blocking air from entering. When they exhale, the dressing flutters open, letting trapped air escape.
But if that air gets trapped inside and can't escape, we enter tension pneumothorax territory. This is a true, life-threatening emergency. The pressure in the pleural space builds so high that it collapses the lung, shifts the entire mediastinum, compresses the heart, and shuts down venous return. You will see severe dyspnea, extreme tachycardia, cyanosis, neck vein distension, absent breath sounds on the affected side, and the hallmark sign, tracheal deviation away from the collapsed side.
And if you see that tracheal shift, you don't wait for a chest x-ray. The provider must perform an immediate needle decompression to release that trapped air, followed by chest tube insertion connected to a water-sealed drainage system. Now, shifting to vascular emergencies, let's talk about pulmonary embolism, or PE. Most PEs arise from deep vein thrombosis in the lower extremities, and they're driven by Virchow's triad: venous stasis, endothelial damage, and hypercoagulability.
Virchow's triad is an absolute favorite on licensing exams. When that clot breaks off, it travels up the vena cava, through the right side of the heart, and slams into the pulmonary arteries. The clinical presentation can be incredibly sudden. Unexplained dyspnea, tachypnea, chest pain, and a very distinct, overwhelming feeling of impending doom. The patient looks you in the eye and tells you they feel like they're going to die. You must act immediately.
For diagnostics, a D-dimer test is helpful because it measures clot degradation, but it's not specific. The gold standard for a definitive diagnosis is a spiral CT scan, also called a CT angiography or CTA, which requires IB contrast. If the patient has renal failure or an allergy to contrast, we use a ventilation perfusion or VQ scan instead.
And once a PE is suspected, you start oxygen and immediate anticoagulation with heparin or low molecular weight heparin like enoxaparin. If it's a massive, hemodynamically unstable PE, they may need fibrinolytic agents like tissue plasminogen activator or TPA to physically dissolve the clot.
Now, let's pivot from the pulmonary vessels back to the airways, specifically the highly reactive bronchial tree in asthma. Asthma is characterized by bronchial hyperreactivity and reversible expiratory airflow limitation. But we have to look closely at the dual-phase immunological response. The early phase response happens within minutes of exposure to a trigger like pollen or dust. Mast cells degranulate, releasing histamine and leukotrienes, leading to immediate bronchospasm, vascular congestion, and mucus secretion.
Right, but then there's the late phase response, which develops 4 to 6 hours later. This is driven by an influx of inflammatory cells like eosinophils and lymphocytes. This phase causes severe airway inflammation and swelling that can last for days. This is why bronchodilators alone aren't enough. We need corticosteroids to treat that late phase inflammatory cascade. And if this chronic inflammation is left untreated, it leads to airway remodeling, permanent structural changes like fibrosis and smooth muscle hypertrophy.
Which leads us to the most severe, life-threatening form of an asthma attack, status asthmaticus. This is an extreme medical emergency where standard bronchodilators and corticosteroids fail. The airway is so swollen and plugged with mucus that the work of breathing is astronomical. If you are auscultating this patient's lungs and the loud wheezing suddenly stops and you hear nothing, that is a silent chest. It is an ominous sign of impending respiratory arrest.
That silent chest means there is literally not enough air moving to create a sound. You must call the provider and prepare for immediate intubation and mechanical ventilation. To prevent patients from ever reaching that point, education is our strongest tool. Let's walk through the exact 7-step protocol for using a metered dose inhaler with a spacer. Step 1. Shake the MDI with the spacer attached. Step 2. Breathe out fully, away from the spacer.
Yes, don't blow your breath into the device. Step 3. Put the mouthpiece in your mouth and seal your lips tightly around it. Step 4. Press down on the canister exactly once. Step 5. Breathe in deeply and slowly. If the spacer makes a whistling sound, you're breathing in too fast. Step 6. Hold your breath for 5 to 10 seconds. And step 7. Breathe out slowly.
Perfect. And if that inhaler contains an inhaled corticosteroid, they must rinse their mouth with water and spit it out afterward to prevent oral candidiasis or thrush. For patients using nebulizers at home, teach them to wash the equipment daily with warm soap and water, rinse it, and then soak it for 20 to 30 minutes in a 1-to-1 mixture of white vinegar and water before air drying. And warn them to stay away from over-the-counter combination asthma drugs containing ephedrine or epinephrine. They stimulate the central nervous system and cardiovascular system, which can be incredibly dangerous for anyone with underlying heart disease.
Let's move to chronic obstructive pulmonary disease, or COPD, which is progressive and characterized by persistent airflow limitation. It's really a combination of chronic bronchitis, characterized by a chronic productive cough for at least 3 months in 2 consecutive years, and emphysema, which is the physical destruction of the alveoli. This destruction leads to a loss of elastic recoil, severe air trapping, and a barrel chest.
And because their lungs are permanently damaged, patients with late-stage COPD often become chronic carbon dioxide retainers. This changes their entire respiratory drive. In a healthy person, high CO2 levels trigger the brain to breathe. But in a chronic retainer, the brain gets used to high CO2, and their drive to breathe becomes low oxygen levels. If we blast them with high-flow oxygen, we can actually knock out their stimulus to breathe. That is why our target SpO2 for a severe COPD patient is strictly 88 to 92%, using low-flow oxygen therapy.
That 88 to 92% window is a classic clinical safety checkpoint. Now, to help these patients manage their dyspnea and air trapping, we teach breathing retraining. Pursed lip breathing is crucial. They inhale slowly through the nose and exhale twice as long through pursed lips, like they're blowing out a candle. This keeps the positive pressure in the airways higher for longer, preventing airway collapse. We also teach diaphragmatic breathing to maximize their chest expansion using the diaphragm rather than tired accessory neck muscles.
We also have to address the severe cachexia and weight loss we see in advanced COPD. Breathing takes so much energy that these patients are in a constant hypermetabolic state. We must teach them to eat small, frequent, high-calorie, high-protein meals. They should rest for 30 minutes before eating and avoid drinking too much fluid with meals so they don't feel prematurely full. We also need to talk about sleep hygiene and sexuality. They should use their bronchodilators before sexual activity, plan intimacy for late morning when their breathing is best, and use positions that require less physical exertion.
That's incredibly practical advice that patients are often too embarrassed to ask about. Finally, let's look at obstructive sleep apnea, or OSA. This is characterized by the repeated collapse of the nasopharyngeal tissue during sleep, blocking the airway for 10 seconds or longer. Obesity is the single greatest risk factor, and it's highly prevalent in males. Untreated, the constant nighttime hypoxia leads to systemic hypertension, cardiac arrhythmias, heart failure, and stroke.
And daytime sleepiness can be deadly if they're driving. Our priority as nurses is airway safety and oxygenation. We have to educate these patients on CPAP compliance. CPAP, or continuous positive airway pressure, acts as a pneumatic splint to hold that airway open. We must teach them to avoid alcohol, sedatives, or smoking before bed, as these relax the airway tissues even further and worsen the obstruction.
It's all about keeping those airways open and preserving gas exchange, whether they're awake or asleep. And with that, we've covered the full spectrum of lower respiratory challenges. Keep these clinical signs and interventions close to heart as you head into your clinical rotations and exams.
Absolutely. Thank you all for listening. Study hard, and we'll see you next time.